Hi, my name is George Berdejo, and I am the Director of Vascular Ultrasound Services at Montefiore Medical Center in New York City. I'm a registered vascular technologist. I'm also a fellow for the Society of Vascular Ultrasound, and today I'm going to be going over carotid artery ultrasound techniques and some pitfalls and pearls and other techniques to help you or to sort of guide you through the performance of carotid artery ultrasound. So let's get started. Here, what we're doing here is using an L9, what is this, an L93 transducer, really the workhorse for carotid artery testing. And we're going to start out the evaluation by starting at the base of the neck, as far down as you can go, and identifying the origin of the common carotid artery. Now, the anatomy is a little bit different on the right than it is on the left. And on the right, you can almost always identify the origin of the common carotid artery. If you look at the screen here, and my pointer, I'm outlining the common carotid artery. Here's the jugular vein. As I point the transducer's chordad, what you're seeing here is the common carotid artery as it joins with the subclavian. This is the innominate. Here's the carotid. And I'm going to turn long axis here. And here we have the origin of the common carotid artery. Now this is important because you always want to be able to evaluate the carotid as far proximal as you can. The reason for that is because evaluation of the waveform at this portion will tell you about the potential for disease proximal to that level. So what I like to do here is put the color flow on and make the appropriate adjustments. I'm just going to increase the color gain a little bit. And then what I like to do is just put a sample volume in at that level and take a quick look at the waveform. Now there are two things that we should be looking for here. It's the velocity itself and also the shape of the waveform. Just steering the color flow box there to optimize the color flow image. And let's just take a quick look at the spectral waveform and see what it looks like. Now what we're looking at here is a velocity of about 120 centimeters per second, but really what's important is to note the upstroke here. And you see how very quickly the waveform gets from the onset of systole to its peak. I'm just going to update a second, make sure I'm in that vessel. And let's just freeze this quickly and just take a quick look. Here's my pointer. Here is the onset of systole, and this is the peak. All vessels in the carotid artery circulation should really have a rapid upstroke. The other important thing to do at this point would be to compare this waveform to the contralateral side. Keep in mind that all studies should be bilateral, always comparing the corresponding waveforms to the contralateral side at the same level. And all studies really should be bilateral. What I'm going to do is go back to the 2D image then. And what I like to do is to put the color on and just very quickly scan through the carotid artery to the level of the bifurcation, making the appropriate adjustments as I do that. I'm just steering the color box now to the other side. I'm going to decrease the color gain just a little bit and work my way up to the bifurcation. Now I'm allowing the color flow image to tell me whether or not I need to sample at any point between the origin of the common carotid artery and the carotid bifurcation. This is a very nice normal image. So what I'll do at this point then is go back and obtain my second velocity. And what I do typically is find the bifurcation, which is right here. Here's one vessel. This is the other. And then go back about 2 to 3 centimeters proximal to that level in the common carotid artery, somewhere where the vessel is disease-free and where it's straight. Now this is important, especially in labs who use an ICA to CCA ratio to determine the percent stenosis within a vessel. I'm going to make the appropriate adjustments angle-wise. Now, if you look at this image closely, what you see is that the Doppler angle cursor is parallel to the vessel wall, and that the Doppler angle has been adjusted to 60 degrees, and that's the appropriate angle. We will then update to get the second flow velocity within the common carotid artery at its midpoint. Now this is an important measurement, again, as I noted, because this is the one that you'll use for calculation of your ICA to CCA ratio. So I'll just freeze that and then acquire the velocity information. So we can hit calc. And here's your first caliper. We'll set that at the peak. And then we can get a second caliper up, and we set that right here to get your diastolic flow velocity. In this case, the peak systolic velocity in the mid portion of the common carotid artery is 107 centimeters per second. The end diastolic flow velocity is 33.4. The other thing I want you to note is that, I'm just going to put a pointer on here, the end diastolic flow velocity is calculated at 100 milliseconds prior to the start of the systolic upstroke, which should be somewhere in this area. You don't necessarily have to get a caliper out to make that measurement, but you have to be sure to get your diastolic velocity measurement somewhere in this area. It shouldn't be anywhere else. I've seen some techs make the mistake of measuring it here or in other places. It should always be measured somewhere in this area right here. Then unfreeze. I'm going to go back to the 2D image, excuse me, put the color back on, and again, allowing the color to determine where within the carotid artery circulation I'll be obtaining flow velocities. Now in this case, the carotid artery is normal. However, in some patients you will have disease. Now in the old days when we didn't have color, we used to have to stop and sample all of the various areas where we suspected that there was disease. But with an appropriately set color flow image, we can allow the color flow image to tell us where to stop and sample. Now, in the absence of disease, the next stop in the carotid system would be the carotid bifurcation. And again, here we have one vessel, and this is the other. So what I'll do here is then identify the carotid bifurcation, get it in the center of the image. Typically, I like to turn the color off. We don't need that anymore. Get the sample volume up. Again, make the appropriate adjustments. Make sure the Doppler angle cursor is parallel to the vessel wall, somewhere just proximal to the carotid bifurcation, and get that second waveform within the common carotid artery. Again, just proximal to the carotid bifurcation. We see a nice normal waveform here, good sharp upstroke, nice acoustic window. Get 4 samples that are representative, 4 or so that are representative of the vessel that you're looking at. Freeze, and then acquire the velocity measurements. By the way, don't forget to label as you go along for documentation purposes. That's the peak systolic velocity, and then the end diastolic flow velocity. In this case, the peak velocity is 90 centimeters per second, end diastolic flow of 33.4. No plaque in this vessel. Again, this is a normal study. Go back to the 2D image. Now, the next important thing is to be able to identify beyond the bifurcation the 2 bifurcation vessels, the internal and the external carotid artery. And there are a couple of ways to do that. I immediately see 2 vessels here. This is the well, my guess would be, without any other parameters, just looking at the size of the vessel, my guess would be that this is the internal. Let's just get the pointer up here. This would be my internal. Now I'm pointing the transducer toward the face. This is the second vessel. My guess, based on anatomic location and transducer position, is toward the face external, away from the face, and because of the larger size and the location of the bulb, internal. But you really should confirm that by placing a sample volume in the vessel and just taking a quick look at the Doppler spectral waveform. So what I do typically is I like to get that sample volume out a little bit distal into the vessel that I'm evaluating. And let's just take a quick look at the flow waveform. So we have a flow waveform here that is yielding continuous forward flow throughout the cardiac cycle with what looks like good amount of diastolic flow. Let's take a quick look at that other vessel and see what that looks and sounds like. Let's make the appropriate adjustments here. Let's update and get a much sharper peak here, but still good amounts of diastolic flow. So based on the anatomic information, I would have guessed this was external and the other was internal. Another thing that we can do is we can do a temporal tap. So let's take a quick look. My guess right now is that this is external. So what I do is I locate the superficial temporal artery around the ear, And what I'm going to do is some light tapping and look for oscillation of the spectral waveform and see if there's any response. And you can see that as I tap the temporal artery, let's just freeze that image, we see some oscillation in the spectral waveform here. Now, one of the other important things to do is that if you do see oscillation, let's just very quickly go back to that other vessel and make sure that there's no oscillation in this vessel, because if you see that oscillation in both vessels, then this technique really doesn't work well in terms of identifying the internal versus the external carotid artery. I want to put up the volume a little bit, so I want to be able to hear the sound as well. Let's take a quick look. Let's tap. You can see there's really no response here to temporal tapping. So now my guess, based on the shape of the waveform, the anatomic location, the sound, and the amount of diastolic flow, is that I'm looking at the internal in this case, and that other smaller vessel is the external. Now once I've, oh, here's the other thing you can do, by the way. Let's take the pulse wave off for a second. Let's put the color flow on and see if we can identify branches. You can see here in this vessel we have a couple of branches that are easily seen. Here's one, here's two. And again, it's just more confirmation. This is the other vessel. Don't really see any branches here. Let's turn transverse. Sometimes transversely, you can determine based on size and the presence of branches. Again, here are some branches in this vessel. This is the external carotid artery based on all those parameters. And it's a good idea to use all the parameters that are available to you when determining or when trying to distinguish the internal from the external carotid artery. So now once we've made that determination, we can go back now and start to evaluate those vessels. This is a nice image of the internal carotid artery. Let's just put the color on very quickly. I'm going to steer that to optimize the color flow image. I'm going to decrease the color scale a little bit as well. And what I like to do is then just follow this internal carotid artery as far out as I can get with the color flow image. Just going to increase the gain a little bit. And this is a very nice image here of the distal internal carotid artery. Just going to invert the color because we like to keep the arteries in red and the veins in blue. And I'm way out here now, almost to her ear. If you just take a good look at this. And this is pretty far. This is about as far as you can get with the internal carotid artery. And it all looks normal based on the color flow image. Of course, we always have to go back and get the Doppler information to confirm that. But once I've determined based on the color flow that it looks normal, what I'll do now is I'll just take the color flow image off and start to get some of that spectral information. So let's first optimize the 2D image. I'm use a little bit of a more posterior approach here. Great image. So let's first optimize the 2D image. Go back to that origin. I'm going to steer to get the appropriate angle. And let's listen to what's going on at the origin here. Now, one thing to be aware of, especially in bulbous vessels, and it may not happen here, but let's take a quick look. This is the near wall, or by the flow divider. Let's just take a quick look at the waveform, very characteristic of an internal carotid artery. But let's move it out further away from the flow divider and see what happens. In many cases, and you see it here, you get this flow separation phenomenon, which is not unusual, especially in patients with very bulbous ICA origins. So my recommendation is that when you're acquiring the proximal ICA velocity, get as close to the flow divider as possible. Let me just update this and optimize the image again. Get as close to the flow divider as possible so that you're displaying a waveform that's representative of the vessel that you're looking at and also representative of the pathologic condition, in this case normal. So a few waveforms. And then we can freeze that. I'm going to turn the gain down a little bit to go a little bit over gained here. And what happened there was my patient just swallowed, and that's okay, not a big deal. Just update the image. Get a couple of representative waveforms, freeze, and then again, acquire your velocity measurements. Peak systolic velocity, and then the end diastolic flow velocity. And here the velocities are 82 for a peak end diastolic velocity of 27, well within normal limits. And again, you'll be documenting all of this. In some cases, The machine will do it for you. You may be acquiring hard copy images. You may have a PAC system. But all this information should be documented and then provided to the interpreting physician for his interpretation. So again, once we're done with the proximal portion of the internal carotid artery, what I do is put the pulse wave back on and update. And what I like to do is step through the carotid system. I'm going to steer this now so that we're parallel to the wall. And then look for any areas of flow disturbance. Again, by the color flow image, we've determined that this vessel is normal, but I'll just step through as far distal as I can in this vessel. Again, optimizing the image first, placing the sample volume. I'm going to increase the gain here a little bit, maybe a little bit less than that. And now we're in the distal internal carotid artery. We'll freeze. Again, acquire the measurements here in my peak. And the end diastolic flow velocity, again, well within normal limits, a peak velocity of 70 centimeters per second with end diastolic flow of 29 centimeters per second. Now, once we're done evaluating the internal carotid artery, we can then turn our attention to the external. And our protocol calls for evaluation of the external. Again, internal away from the face, and a very subtle movement of the transducer. You may not have noticed any movement at all. Will reveal the external carotid artery. So again, internal, very subtle movement, and we can visualize the external carotid artery. Let's optimize the 2D image. Get our sample volume up, steer that so that, again, we're parallel to the vessel wall. And let's see what the waveform looks like now. See, it sounds different. A much sharper peak. We've done the temporal tap for the oscillation. We can do that again. I just decreased the scale. And again, we can see the oscillations there. And once we get a few waveforms that we think are representative of the vessel, I'm going to update actually. See, I wasn't in the vessel there. And that's okay. Every now and then you'll move, no problem. We can update, fix that image. And you can hear the difference in the waveform. So your ear is an important tool in the process of scanning. You need to listen to that waveform. If it doesn't sound like what it did before, just update, fix your image, and get that waveform. Okay, we can get our measurements. Here's the peak and the end diastolic flow velocity, 71 and 23 respectively. Waveform looks normal. Don't see any evidence of plaque. We can unfreeze, take the pulse wave off. At this point now, what we have to do is evaluate the vertebral artery. And if you have trouble finding your vertebral, one of the tricks is we'll turn the patient's head back just a little bit and use a very anterior approach to identify the common carotid. Now, typically, we would scan the carotid artery from a more posterior medial approach, or lateral approach. This time we're going to go anterior, and then just point the transducer laterally. And typically what you get is this type of image here. So here is the common carotid artery. Move that transducer laterally, and this is the classic image of a vertebral artery. What we have here is the vertebral artery and the bony process, artery and bone casting a shadow. And this is a classic image. And the best way to find the vertebral is to do it this way. Once I've identified this image, what I do now is put the color on. And the primary reason to look at the vertebral is to assess it for flow direction. What I'll do now, again, remember we said we keep all arteries in red. The flow right now is moving away from the transducer. The head is oriented, or the brain is oriented so that, or the image is oriented so that the brain is to the left and the heart is to the right. So in this case, the flow should be moving from the right to the left or away from the transducer, and we've coded that flow as red. So it's moving in the appropriate direction. I'll put the pulse wave on, place the sample volume, and then update. And this is, again, a very classic vertebral artery waveform. It should look very similar to that of the internal carotid artery. Lots of diastolic flow because it perfuses the brain directly through the basilar artery. Just want to optimize that just a little bit. Just sample right here and take a quick look at what that looks like. And there you go. Good sharp upstroke, lots of diastolic flow. You can freeze that and do our calcs. Here's your peak velocity and your end diastolic flow velocity. Now the vertebral arteries are a little bit different than the carotids. This would probably be the only part of the carotid circulation where you don't have symmetry. Everywhere else within the carotid artery examination, you should have symmetry. The vertebrals will be a little bit different. Often the velocities on the right will be greater than those on the left, so you shouldn't be surprised about that. I'm going to just unfreeze and go back to the 2D image here. Now, if you have to evaluate the vertebral artery for atherosclerosis, it's unlikely that you're going to see atherosclerotic disease anywhere in the mid portion of the vertebral artery. Most often that would happen at the origin. So what we do is identify the vertebral artery in its mid portion and just work your way back using the color flow image as a guide. We're going to work our way back all the way to the origin here, and here is the vertebral artery. And again, using the color as a guide, here's your vertebral. I'm going to take that all the way back to its origin. Now you can see there are multiple vessels here. If I had just gone to the origin, I might have mistaken this for a vertebral artery or any other branch. In fact, this is the origin of the vertebral artery. If you wanted to evaluate it for atherosclerosis or stenosis, you take it to the origin, identify that, turn the color off, place the sample volume. Let's just steer this to create the right angle, and let's update and get a velocity here. You see the velocity is about 80 centimeters per second or so. I just want to update that and see if we can optimize that signal. And that's much better. Turn the gain down to eliminate some of that background noise. And this is a waveform and a velocity that's well within normal limits. So that's the technique for evaluating the origin of the vertebral artery. Now there was one thing that I didn't mention at the onset. We want to start off every evaluation, again, with a transverse sweep. And I did mention the transverse orientation for identifying the origin of the common carotid artery. Again, here's the origin. You want to work your way up to the bifurcation. Here is your common carotid artery, and this is your internal jugular vein. What you want to do is just follow that up transversely all the way up to the level of the bifurcation. And we can see here is the carotid artery bifurcation. Here's one vessel, and this is the other. Again, we've already identified this as the external carotid artery, and this is the internal carotid artery. The nice thing about the transverse sweep is it allows you to get a preview of the carotid system, allows you to know plaque if there's any present, the level of the bifurcation, and the amount of plaque burden within the arteries. Within the first 30 seconds or so of the beginning of the examination, you pretty much have a good idea about how long it will take and how difficult the examination will be. So it's a good idea to start off every examination with a nice transverse sweep of the carotid artery system. So I've demonstrated the techniques that you can use to evaluate the carotid arteries. Of course, you would repeat the same steps on the contralateral side. Keep in mind that every examination should be bilateral and include examination of the common carotid, the carotid bifurcation, the internal and external carotid arteries, as well as the vertebral artery. Now, in some cases, you may also want to evaluate the subclavian arteries, and I'll show you how to do that right now. Just put a little bit of gel in the transducer and take a quick look at the subclavians. Now, a good indication for looking at the subclavian would be in a patient who presents with posterior circulation symptoms or who has abnormal flow changes, waveform changes in the vertebral artery. Now, in this case, what we can do is, again, identify the common carotid artery and work your way down to its origin. In this image, again, here is your common carotid artery. This is your subclavian. Right here is the origin of the subclavian. Here is your innominate. So, working your way out toward the shoulder, here's the subclavian. And this is, of course, the infraclavicular portion of the subclavian artery. And typically what you want to do is, again, optimize your image. In this case, proximal on this end and distal on this end. Once you've optimized your image, we can put your pulse wave on. Let's steer that to get a good angle. Again, we're at 60 degrees and parallel to the vessel wall. Update. Now in this case, we should be expecting a multiphasic waveform because the subclavian artery is in fact perfusing the arm. In many cases it will be triphasic. In this case we actually have 4 phases of flow, and this is absolutely normal. Let's just freeze that and I'll show you the 4 phases of the spectral waveform: forward flow, a reverse flow component, a second forward flow component, and then a second reverse flow component. So in this case, 4 phases of flow, and that's absolutely normal for the subclavian artery. In the presence of stenosis, you should expect to see the flow changes that are consistent with the various degrees of disease. Probably the first thing you'd see is a loss of the reverse flow component. You can take this examination out into the periphery and into the chest and shoulder. Keep in mind that the first impediment to the imaging will be this huge bone here, which is the clavicle, so you'll have problems seeing the subclavian vein here, but you can take it out at least to the level of the clavicle and then further out. I'm just going to add some gel here, and let's just image quickly the infraclavicular portion of the subclavian artery. Again, access is important. Here's the clavicle. We just imaged it supraclavicularly, and I'm going to take it out here into the infraclavicular portion of the subclavian artery, and let's take a quick look at that. There is the subclavian vein. Superior to that, you would find the subclavian artery, and you can see a couple of branches there, but that's a very nice image of the subclavian artery. And again, let's just put the pulse wave on and take a quick look at the subclavian at this level. Now, it's important also to note that when you're looking at the subclavian artery in a patient who has a suspected subclavian artery stenosis based on changes in the vertebral artery waveform, you really want to do a comparison of the right subclavian to the left subclavian, again, looking for asymmetric changes. Again, in this patient, she's absolutely normal, and we don't see any of those changes. But, and in my opinion, it's probably a little bit easier to identify the subclavian artery infraclavicularly. But if you're going to make those comparisons, always make sure to look at the contralateral subclavian artery at the same level, look at the waveforms, and look at the velocities before rendering a diagnosis. So that's the carotid artery evaluation, including the subclavians. I hope it's been helpful. And good luck to you in your carotid artery imaging. Thanks a lot.